Onc Live Insights is a video editorial program produced by Onc Live.
The genetics and the molecular profile of pancreatic cancers have really been difficult initially to figure out what would be the major targets for us to look for. But over the past decade, we have learned more about this disease than we had any time before. However, there's a very complex disease. The molecular abnormalities are all over the place. We don't have really a defined genetic abnormality that we think is driving the tumor, except for the KRAS mutations, which are predominant in more than 90% of the patients. There is also the knowledge that many tumor suppressor genes are mutated in this type of cancer. For example, P53 is frequently mutated in pancreatic adenocarcinoma. We also have other gene mutations, which is the P16 gene mutations, and also DPC4. So these are all tumor suppressor genes, which creates a problem for us because targeting the tumor suppressor genes in therapy is very difficult. With KRAS being mutated in over 90% of the patients, we were hoping that we have some drugs that can target that pathway because we think it's an important one to initiate the cancer, but also maintain the disease process. But at this point in time, we have not been successful in identifying drugs that are really very good and specific for the KRAS pathway. And that's a work in progress. And more recently, there has been an initiative by the National Cancer Institute to focus on tumors that are KRAS mutated to find ways of trying to deal with that pathway. And hopefully that will be something good for pancreatic cancer in the coming years in terms of finding new treatments.
The first question is to discuss the molecular and genomic characteristics of pancreas adenocarcinoma, and they have been relatively well described. It's a genetically complex disease characterized by a number of mutations, KRAS being almost ubiquitous, and the absence of KRAS nearly raising the question, is it pancreas cancer? Although there probably are a true small number of KRAS wild-type tumors. P53, SMAD4, and P16 are the main genes. And then there are a smattering of lower frequency mutations in pancreas cancer. The average pancreas cancer has about 63 genetic changes in its disease. In terms of defining outcomes based on the genomic profile for pancreas cancer, if we look at the major tumor suppressor genes, the greater the number of tumor suppressor genes, there's a suggestion that those patients fare poorly. So those who have mutations in KRAS, P53, SMAD4 compared to KRAS alone, suggestion is to say biologically that may be a less favorable prognostic subgroup, and we and others are looking at that to sort of define better characteristics that would segregate groups of patients with pancreas cancer. In terms of validated biomarkers for decision making, there is none that is validated for clinical practice, although arguably the presence of a BRCA mutation in BRCA1, BRCA2, or PALB2 might be a marker of a group of patients that have defects in homologous repair, and that subgroup of patients may be more likely to benefit from platinum-based therapies and experimentally PARP inhibitors. And they're research questions that for which there are a number of trials underway in pancreas cancer at the current time. In terms of other markers, SPARC has been a putated marker. The MPACT study, which evaluated gemcitabine nab-paclitaxel compared to gemcitabine, had a very nice correlative science counterpart, which looked at SPARC in tumor, in stroma, and measured in the blood. And there was no correlate with outcome. So that hasn't held up despite initial data suggesting that it could have utility. Other markers have included HENT1, which some data initially in metastatic disease in retrospective reviews suggested that it could be a marker of enhanced benefit from gemcitabine. However, a recent randomized phase 2 evaluating HENT1 did not show a difference when segregated by high versus low levels, and also a drug which was predicated to work better independent of HENT1 didn't show an improvement in outcome. There's still discussion as to whether it's been optimally measured, and there are a couple of different antibodies that have been used. So I think the story isn't fully told. And there's also suggestion that in the adjuvant setting, despite the negative data in metastatic disease, that there could be utility to HENT1. And current studies, current adjuvant trials are collecting that data. But I would say right now, in terms of clinical decision making, it's not something that we use in day-to-day practice.